to the other major type of arthritis, rheumatoid arthritis. And almost everything you just heard does not apply to this condition. So this condition is a chronic, progressive, systemic meaning not just the joints, inflammatory. I said the other condition, inflammation, was a small part of it. This is an inflammatory condition that affects the entire body, the major focus of which is the joint. And this is a condition that affects younger individuals. Again, for the most part, women, but women in the childbearing years. So you see this in women in their 20s, 30s, and 40s. It can affect women in their 60s, in their 80s. As we get older, you see men develop it more often. But overall, 2 to 3 times more often in women. And this is a rapidly destructive type of arthritis. And as you can see from this cartoon, there are different structures that we're trying to emphasize here. Here, it's not so much the cartilage that is the focus of the defect, but it is the lining of the joint, the membrane which is called synovium, the synovial membrane, where the inflammation seems to focus. The synovial membrane, which is usually very thin, becomes infiltrated with inflammatory cells and starts to take on the characteristics of an invasive tumor. It starts to insinuate itself into the bone and the cartilage and directly erodes it. Very different behavior than what we were talking about with osteoarthritis. The joint distribution is different. Those last joints by the nails, not affected. Middle joints can be affected, but most often the joints where the finger meets the hand, what are called the MCP joints, can be affected. The wrist and the elbow and the shoulder, which I told you weren't affected by osteoarthritis, can be affected here. Hips and knees can be affected, but so can the ankles, the middle of the foot, the toes. And when it comes to the spine, for the most part, it avoids the spine other than the uppermost portion of the neck. So the big contrast here in the distribution of joints, big contrast here in the visualization of the joints. As you can see here, we see soft tissue swelling, which is part of the inflammation that one sees in rheumatoid arthritis. And this is characteristic. This is almost always seen in patients with rheumatoid arthritis. And because the cartilage becomes so rapidly eroded and eccentric, you get these deformities that can develop relatively quickly. When I showed you x-rays of the hands before, you didn't see these fingers that were going in all sorts of directions. Again, this is because this disease, rheumatoid arthritis, is a much more aggressive, much more destructive condition than osteoarthritis. And it's a systemic disease. It's a disease that can affect any part of the body. It can affect eyes, can affect mouth, can affect lymph nodes, can affect liver and spleen. It can also predispose to the development of other diseases. So people with rheumatoid arthritis will get myocardial infarctions, heart attacks, coronary artery disease, lung disease, liver disease, ulcers, more often than patients who don't have these conditions. For the most part, that does not happen with osteoarthritis. Rheumatoid arthritis can affect one's life expectancy. On average, people with rheumatoid arthritis unfortunately live somewhere between 5 and 12 years less than people who don't have the condition. And what we've learned in the last 10 or 15 years is this is a disease where we can make a difference in the ultimate outcome of the condition. If we intervene early with appropriate medications, we can prevent the damage from occurring. How do we treat it? Well, here there's some overlap. We can treat it with non-pharmacologic measures, some of the same things that we talked about with osteoarthritis patients, teaching patients about their disease, using mechanical measures to help protect joints. At the bottom, we can use surgery when nothing else works. But the emphasis here is really the drugs. And there are lots of drugs we have available to us. We have the non-steroidal, the aspirin-like medications. But interestingly, we don't emphasize these because even though they can help the symptoms, they do nothing to help the disease. And we have better medications that treat the disease. We can use cortisone-based medications. We can inject them into the joints. It will help. We can even have patients take it by mouth. It will help. But we want to avoid them as much as possible because of their toxicity. Sometimes they're very helpful in the short term to bridge the gap between when we introduce a medication to help the disease in the long term and when they begin to work, because many of them don't work instantaneously. So cortisone-based medications are helpful in rheumatoid arthritis when given by mouth. But the major emphasis in the treatment of rheumatoid arthritis is this family of conditions called, medications called disease-modifying anti-rheumatic drugs, or DMARDs. These are medications that can actually arrest the condition. And there are many different ones available. There are some that are taken orally. The one that is most often discussed is methotrexate. Methotrexate, which started off as a medication to treat cancers, has become the mainstay of therapy for treatment of rheumatoid arthritis. We use much lower doses than the oncologists use. We use doses that the side effects are, for the most part, predictable, and we can easily monitor for them. There are other options besides methotrexate and the oral medications, and these are the biologic medications that have become available over the last decade. And to understand how the biologic medications work, one has to understand a little bit about the physiology of rheumatoid arthritis. I'm not going to go into this in any detail, but I just want to show you how complicated it is. What we're looking at here are the cells that produce the chemicals that lead to the damage that occurs in the bone and the joints. And you can see that there are many different inflammatory cells that interconnect with one another, and they produce chemicals that stimulate other inflammatory cells, that stimulate other inflammatory cells, that stimulate other inflammatory cells that make the chemicals that destroy the cartilage and bone. These chemicals we refer to as cytokines. These are how inflammatory cells talk to one another. And we know that there are certain cytokines that encourage inflammation. You see them on the left. And there are other ones that discourage inflammation. You see them on the right. And what happens in rheumatoid arthritis is you have an abundance of the ones that encourage inflammation. Well, we now have medications that can prevent the inflammation that those cytokines encourage. Yeah. We're not going to go over this in any detail, but I just want to show you how different things are. 1982 is when I started my rheumatology training. Those are the medications that we had available to us. What you see on the right is what is available now. There are only 2 medications that still are on the list from 1982. All the ones under that dotted line are biologic medications. These are medications that have become available in the last decade, and they all work by interfering with that family of cytokines, those chemical messengers that tell one white cell to cause or prevent inflammation. Most of the biologic medications that we use now are directed against one cytokine called TNF, and they include Enbrel, Cimzia, Humira, Simponi, and Remicade. There are 5 different medications. They all work similarly. Their structures are slightly different, but they all have similar characteristics. They work to minimize the inflammation, to minimize the cartilage erosion, to minimize the bone destruction, to try to maintain stability of the joint. They've been shown to prevent some of the other consequences of rheumatoid arthritis. They lower the risk of heart attacks. There's recent data to suggest they lower the risk of cancers, even though when you read the warnings on these medications, there is a warning about the possibility of these medications encouraging cancer. Recent data suggests the opposite. Just this week, an article came out showing that they decreased the risk of rheumatoid arthritis patients developing diabetes. So these medications have a profound effect directly on the disease and also on some of the indirect consequences of the disease. Methotrexate's first. These anti-TNF biologic medications have become the second most important weapon in our armamentarium. We also have some other weapons that have become available. There are 4 other medications that work elsewhere in this inflammatory cascade, and they're listed here. And these are primarily used for people that haven't responded well enough to methotrexate or the Enbrel-like medications. And these include Orencia, Rituxan, Actemra, and Kineret. If you read the newspapers, you're also going to read about some of the newer things. And one of the most exciting ones is a family of medications that work by inhibiting the structure on the right, what's called JAK. So JAK is a protein that exists in inflammatory cells, and we now have molecules that will interfere with the consequences of JAK stimulation. This is something you're going to hear more about in the next year, because there's likely to be a new medication approved for rheumatoid arthritis, which is again a pill. These biologic medications up until now, these new ones over the last 10 years, were all injectable or infusible medications. So we've made such progress that we've been able to dissect out the inflammatory process to such a precise extent that we're now coming up with selective inhibitors of certain chemicals in this process that command the inflammation and the consequent joint destruction. And now we're at a point where we've developed pills, not just injectables, but pills that can inhibit those chemicals. So I just want to close with this. One of the obstacles for us as rheumatologists to effectively treat not just rheumatoid arthritis, but any type of arthritis, is that patients wait too long, in part because they think arthritis is just a consequence of aging. It's not just a consequence of aging, and it's not just one disease. Even if it's osteoarthritis, which does occur as we get older, there are things to do to try to minimize the consequences of it. Another problem is there are not enough rheumatologists around, and we're trying to teach the PCPs, the family practitioners, the internists, more about these conditions so that they can deliver more effective treatment, but that's only happened to a small extent. A lot of physicians still don't know about all the options that are available, not just drug therapy, but the resources that we have out in the community, the Arthritis Foundation, sending patients for physical therapy. These are underutilized. Local therapies, especially for osteoarthritis, injectable therapies into the joint for osteoarthritis, underutilized. For osteoarthritis, there's been overemphasis on the pills, which for the most part only treat the pain, don't do anything to treat the disease. But for rheumatoid arthritis, there's been underemphasis on the pills, on the right pills, which can actually change the course of the disease.